Hello, good afternoon. My name is Mішель Tusan. I'm a physiotherapist working in Brussels. I have an expertise in ventilation with Duchenne muscular dystrophy, and it's the reason why the organizers asked me to speak about non-invasive ventilation in Duchenne muscular dystrophy. Where are we now? So here we go. So there are three main respiratory concerns in those patients. The first concern is home mechanical ventilation. The second is the swallowing problems. And the third one is the emergency and airway clearance techniques. But before to join those three main concerns, I will introduce a little bit the respiratory evolution in Duchenne muscular dystrophy. And the very important item to measure is the maximal volume, called the vital capacity. And when we look at the vital capacity in normal subjects, we see that this value is increasing until 20-25 years of age and then progressively decreasing with age. When we look now at Duchenne patients, we see almost the same curve, but all the curve is smaller, and patients are reaching almost 50% of the normal vital capacity when they are young adolescents. And if they have the chance to survive until 30, 40, even 50 years of age, they can reach zero of vital capacity. So it's important to determine adequate respiratory support by measuring the forced vital capacity. If we look at the vital capacity on this figure, you can see that those patients have a decreasing vital capacity, but also that as long as they have 50% or more of vital capacity, normally they should still be able to walk, and there will also be no or few risk for respiratory assistance. It means no ventilation, no need for cough assist techniques, also probably no problem of dysphagia. All the problems are starting when the vital capacity is less than 50%, and at that time, when the vital capacity is lower than 50%, there is a higher risk for respiratory problems and also for respiratory compensation. If we have to compensate for weak muscles and low vital capacity, we will compensate a little bit when the value is a little bit under 50%, but we will compensate more for larger decreasing, and finally, in patients with zero or close to zero of vital capacity, we will need techniques to compensate a lot those patients because they have no forced vital capacity. The restrictive syndrome of those patients can be defined as three problems. The first one is the reduction in maximal volumes, then the reduction in maximal respiratory muscle strength, and finally the reduction in the thoracic and chest compliance. So we come back to the main respiratory concerns. The first one, and we will start with that problem, is the home mechanical ventilation to be introduced in those patients. What can we say about that? The first thing to say is that there is a high level of evidence with the ventilation in those patients. It's very comfortable. It occurs with nasal mask during sleep, and also it's a very effective treatment. You have to know that it provides ventilation. It provides survival over 30 or 35 years of age in Duchenne boys. Currently in Belgium, our oldest patient is 51 years and is still alive. He started his ventilation when he was 17 years of age and lost ambulation when he was 13. Ventilation also requires the expertise of specialized centers, And we can consider that a learning period is almost 3 nights at the hospital. Here we can see the difference between a patient ventilating normally on the left side, and in red you can see a patient with the trend for hyperventilation because this Duchenne patient is breathing quickly and also superficially. And when you are breathing like that, you do not breathe deeply with your lungs, and there is a risk for hypoventilation. In Duchenne dystrophy, this hypoventilation occurs normally between 15 and 20 years of age. Hypoventilation is defined by a PCO2 level in blood higher than 49 millimeters of mercury during sleep, and that was suggested recently by the group of Paris of Orlikowski and colleagues in Garches. When this item is met during sleep, then we can consider that it's an indication to start with nocturnal ventilation with a nasal mask in those patients, and this ventilator will just support ventilation and go finally to a normal level of PCO2, so hypoventilation will be improved drastically with this treatment. What is the place for the tracheostomy? Finally, there is currently a very poor place for tracheostomy. The tracheostomy is never used as the first choice for nocturnal ventilation. Also, it's less and less used as the first choice for 24/7 days patients. And the last indication for a tracheostomy is when first there is no further access to non-invasive ventilation. NIV is non-invasive ventilation, or when there is a need to direct suctioning. When you need to have suctioning, for instance, every 5 minutes, then yes, probably you still need the placement of tracheostomy. This is a very nice illustration of one of our patients with Duchenne muscular dystrophy. This guy is 30 years of age, and you see this guy in the mountains at 3,000 meters of altitude. This guy is ventilated 24 hours a day, 7 days a week, with non-invasive ventilation. And you see he's on this slide on a sledge. You can imagine that his ventilator is on his feet. You see the tubing going in the direction of his head. And if you look very nicely on his face, you see his nasal mask, because this guy is ventilated night and day. So I like this slide because it just shows that when you are ventilated, even continuously, it's not the end of your life. A second respiratory concern in those patients is the swallowing problems. There are 3 possible post-swallow disorders with the food and with the drinks. A problem of residues, problem of penetration, or finally a problem of aspiration. This is a figure that we suggested 4 years ago to show the difference between residues, penetration, and aspiration. Residue just means that when you are eating solid food, you can have residues that are staying just upper the vocal cords, and it can stay there for hours sometimes. The problem for residues is that when you go to sleep, for instance, and you are going in the supine position, there is a risk that those residues will go into the lungs to make an aspiration. A second possible problem is what we call the penetration. Penetration is an incomplete aspiration. You clearly see that the bolus of food is taking the direction of the lungs, is going in the direction of the vocal cords, but at the end, finally, it goes in the right direction into the stomach. And the worst problem is the problem of the real aspiration. Aspiration means that the bolus in total or partially is going in the direction of the lungs, and so it means that you have food in the lungs. We have 4 tools to assess swallowing problems, dysphagia in Duchenne muscular dystrophy. The first, the easiest way is just to question the patient and his family on the symptoms. What happens at home? You must know that. So the first question is there regular chest infections at home? Is the patient coughing at night? Is there some loss of appetite? How is the length of the meals? Is it lasting longer and longer? And finally, are there some shocking episodes in the patient? If you have positive answers to those questions, you can think that possibly there should be a swallowing problem in the patient. A second tool is the SSQ, the Sydney Swallow Questionnaire. The Sydney questionnaire is in 17 questions. It is lasting almost 10 minutes when you are well trained to use that questionnaire. And fortunately, this questionnaire is validated in Duchenne patients. Those authors in 2013, Archer and colleagues, suggested that there is a risk for dysphagia when the score is higher than 225. A third possibility of examination is the video fluoroscopy with a swallow contrast product. The good point of this examination is that we have objective data, but the problem is also that it's not easily available in every hospital. And finally, that specifically for Duchenne patients, it's hard to have a good positioning of the patients in the sitting position with these device for video fluoroscopy. Finally, the fourth examination is the fiber optic endoscopic evaluation of swallowing, called also the FEES. And the FEES is a direct observation with an endoscope into the upper airways, and the endoscope is placed just a little bit higher than the vocal cords. So you see here on Wednesday evening in our hospital a consultation with a guy with Duchenne dystrophy, drinking liquids and eating semi-liquid food. And you see that this guy, during drinking and eating, is examined by the physician to see what happens. Are there some residues? Is there possibly some penetration, or is there aspiration? And we saw on one Wednesday afternoon, 4 patients with Duchenne muscular dystrophies. Ages of those patients were 30, 24, 27, and 25 years of age. And we looked on the same afternoon the presence of residues and penetration. And with the FEES, we could see in those patients with liquids and solids and semi-solid food that there were residues, but also risk for penetration on the 4 Duchenne patients. So it's just to illustrate that we possibly underestimate the prevalence of residues and penetrations in those Duchenne patients. This paper is a fantastic paper, very nice paper from a team from the Netherlands. And the first author looked at the difference in dysphagia between CP, cerebral palsy patients, and NM, neuromuscular patients. The most important observation was that in the CP patients, the underlying swallowing problem was related to abnormal control of swallowing, meaning that there was a problem of coordination of the muscles, leading to the risk for aspiration of liquids. Cerebral palsy, the problem is liquids. Opposed to that, with neuromuscular patients, the underlying swallowing problem is muscle weakness, leading to the residue of solids, semi-solids, and pureed food in the upper airways, just higher than the vocal cords. In this paper, they have shown that the prevalence of, for instance, the aspiration of liquids, it's much more important is in CP patients than in the neuromuscular patients, and opposed to that, there was more problems of aspiration and penetration with the solids in the neuromuscular patients, and much lower aspiration and penetration of solid food in the CP patients. It's the reason why in CP we will consolidate the liquids to make that they are more solid. For the neuromuscular patients, we have to take another strategy and to liquefy the food. We have, for instance, Duchenne patients older than 40 years of age, still drinking liquids, but not able to eat for 10 or 15 years already. An important point of discussion is the managing of saliva and oral secretions, leading to bacterial colonization and chronic chest infections. The advice that we can give is to start in the childhood and to train children to sleep on their side and not on their back. Why? Because when people with a neuromuscular disorder lie on their back, the risk for aspiration is much higher. You see this child with a type 1 SMA, younger than 1 year of age, and this child is ventilated 24 hours, 7 days, and you see some saliva expelled by the mouth, and that's the reason why this child is staying all the time on her side to avoid aspiration of liquids. Here, her saliva. So we have seen home mechanical ventilation, we have seen swallowing problems, and finally we will now speak about emergency and airway clearance techniques. In emergency, very importantly, you have to know that we have to avoid the use of long-term oxygen without the association of ventilation. So oxygen may be used, but always together with ventilation. A second point is to use the cuff assistant techniques that we will see later in this presentation. And if the patient is not too much fatigued, we also can use later in the disease progression mucus mobilization techniques. So what is cuff? Cuff is to promote and provide high expiratory flows like this. And so to obtain high expiratory flows, we need to make that patients will be able to cough effectively. So to cough effectively, we have two possibilities. First possibility is to increase inspiration by air stacking. What is air stacking? Air stacking is using an external device to give some inspiration, and we will ask patient to not breathe out during 2 inspiration, and by this way to stack 2 or 3 salvos of air into the lungs. When the patient have more and more air in his lung, it will be able to cough at a higher inspiratory level than without air stacking by this ambu bag, for instance. Another possibility, this is the work of Del Amo Castrillo in 2019, they have shown that we also can train patients using non-invasive ventilation to stack air, and we see clearly on this slide that with breath stacking, thanks to the ventilator, patient can improve their cough peak flow by almost 100 liters a minute. A second possibility is to increase expiration by manual thrust on the chest, and by doing that we will compress air into the lungs, and by compressing air into the lungs we will also have higher expiratory flow and therefore expel mucus from the lungs. In the practice, very often we use 1 and 2 successively. So first we will promote the air stacking to increase inspiration, and after increased inspiration we will also increase expiration by a manual thrust on the chest. There is a device, the device is called the Cough Assist, who is able to mechanically assist both inspiration and expiration mechanically. The problem of this device is that it has a cost, and not every center is able to provide devices to patients. If someone is interested to read more about emergency and about airway clearance techniques in neuromuscular disorders, we have organized 3 years ago a meeting with almost 20 world experts on that topic, and this paper is free access and gives a lot of information on cough assistant techniques. For instance, the main information of this paper is that we have made a kind of summary to know what is the best technique to use to augment cough in neuromuscular patients. And so we have compared 6 different techniques to augment cough. One is MIE. MIE is mechanical insufflation exsufflation plus MAC. This is manual assisted cough. So it means cough assist plus thoracic thrust. And opposed to that, number 6, column 6, is GPB. This is glossopharyngeal breathing. And between 1 and 6, you have different techniques to increase cough. We looked at the costs of those techniques. Also, we made 3 categories of patients from the top to the bottom. The first category was patients with no need for assisted cough. The second category was patients where we will consider the need for assisted cough. And finally, the last group is when there is an absolute need for assisted cough. I think that the originality of this work was to use, you see that on the left side, the FVC, the forced vital capacity. We spoke about this item initially in this presentation. To use this forced vital capacity to know almost if the patient will be part of the first group, the second group, or the third group. And only when you know more about the vital capacity, you will also know more about the technique to be chosen to augment cough in an individual Duchenne patient. When we have used cough assistance techniques, also we can use the peripheral clearance techniques. This is only a question of sputum mobilization. So these are techniques helping to move secretions from the periphery into into the direction of the upper airways. The first technique is deflation. The deflation is just with a strap or with your hand to reduce the volume of the lungs. And when you reduce the volume of the lungs, you will also reduce the caliber of the airways. And when reducing the caliber of the airways, you will increase the airspeed. And when you increase the airspeed, you will favor also the mucus progression in the direction of the throats. This is just to show you that there have been some papers controlling the effectiveness of the strapping with different straps. And what you can see is that, for instance, in a group control, with 50% of the total lung capacity, patients had a mean 3.2 expiratory flow, but with the strapping, you can see that those patients went to 5.9 liters a minute. Sorry, I was a little bit too quick. A second technique is intrapulmonary percussive ventilation. And when we compare percussion on the left side with pressure support, with BiPAP or non-invasive ventilation, with the photo here under of a Duchenne patient using a nasal mask at night, percussion is a technique with high frequency ventilation, also with peaks of pressure. And these peaks of pressure are given with high frequency and also with little volumes of air. So, interestingly, those devices do not require the active participation of patients. So, this is totally passive. It's a kind of ventilation with high frequency. The idea of this device is that the expiratory flows are higher than the inspiratory flows. And this has been shown by a work of Freitag in the Journal of Applied Physiology almost 30 years ago. And they could show that with high frequency ventilation, the expiratory flows are indeed higher than the inspiratory flow, making a flow bias, providing mucus progression from the periphery into the upper airways. So I will conclude now on respiratory care in Duchenne muscular dystrophy. Regarding ventilation, it's important to start non-invasive ventilation, NIV, when nocturnal PCO2 is higher than 49 millimeters of mercury. Nocturnal ventilation is offered via a nasal mask. Tracheostomy is only needed when there is a need for constant suctioning. Regarding the problem of swallowing, we prefer in Duchenne to give liquid than solid food in the oldest Duchenne patients. During emergency, please do not use oxygen without non-invasive ventilation. And when patients have secretions, use effective cough augmentation techniques that we just saw in the previous slides. I thank you for your attention and I wish you success for the rest of the meeting. Bye-bye.